Good afternoon. Hi, folks.
Hi.
Hey, Susan.
Hey. Bill, how you doing?
Just fine. Can you hear me?
Yeah.
Oh, good. What is the difference between Zoom Gov and what the rest of us might have? Does it have more capabilities? Probably cost more.
Yeah. Yeah, that's my understanding. It has some more like
Probably
security.
security. Yeah.
Mhm. Which allows you to hopefully avoid Zoom crashers.
I've been there and done that with my another project I work on, but what I wish is that when someone's in the waiting room, you could interrogate them in some way, even if it's just by chat, so you know who they are, because that was how we got in trouble.
There is an option for messaging the waiting room.
Well, yeah, but it's everybody.
Oh.
It isn't, and they can't reply either in writing or in typing or in speech. So.
Oh, okay.
I just wondered. I thought you guys are so up to date on everything. You'd have all the answers. It's even good to see you. How do you get time away with all that's going on? I was afraid they'd cancel it as things got bad last week again.
Nope, we've been
plugging along.
That's right. Trying to get some, vacations in, and
I hope so.
Yeah.
Well, it's good to see you and looking well and healthy, and that's great.
Good to see you too. You as well.
I haven't met Hope yet, but she seems to be very organized, getting everything out there. And
yeah,
I've been in a number, several state commissions or committees or whatever. I've never felt as well taken care of from a standpoint of information and having what I need when I need it. Right. I don't want to tell everybody that, because then they might think you're doing too good a job or something.
Well, I tell you, I really appreciate that feedback.
That's true.
That's a priority, so that's great. Looks like we've got most folks joining.
Oh, I'm not seeing everybody. Let me fix that.
Oh, yeah.
These are the people that I haven't seen for so long.
Yeah. Welcome, everyone.
Thank you.
Welcome, Abdi. Oh, you're on mute.
Hi, everyone. Yeah, thanks, Susan. Yeah.
Yes.
Yeah.
Good to see you.
Wonderful. Yeah, likewise. Yeah. Yeah.
And I meant to ask you before the meeting, but do you prefer Abdi or Abdisalan?
Both of them. Folks
Okay.
call me. I use my name. So yeah, Abdisalan is the long version. Abdi is a short version. So there you go. Either one of them is fine with me.
Okay.
Whichever is easier for the folks. Yeah.
Okay. Great.
Yeah.
Great. Welcome.
Okay.
All right. Well, I think we've got most folks, actually.
We have everyone that you were expecting, Susan, or are we still maybe missing anyone?
Nope. Looks like we just got everybody, all the HITOC members and Kirsten that we were expecting.
Great. Well, I guess we can go ahead and jump in then if we've got everyone. So just as that we have quite a few new members, we'll go around and do introductions here in a little bit, but we are excited to have quite a few new members on HITOC. So welcome to all the new people. I'm Eric Doolan, the chair of HITOC. I'm the chief operating officer at Pacific Source and have been involved in this work since, I think 2010, and been on HITOC since 2012. So we're really excited to have some new folks joining us with some different backgrounds and different perspectives, and that'll really be great. We'd encourage HITOC members, if you are comfortable, to turn on your camera so we can see your smiling faces, and if not, that's also fine. As you probably saw when we started the meeting is being recorded. And I think you had to acknowledge that coming in, but just a reminder of that. So I think maybe what we'll do is we will start with our new members and do some quick introductions. And so if you just want to give us a little bit of your background and your interest in HITOC, and then after that we will introduce the rest of the existing members. So I'll just go down the list I have in front of me here, and we'll start with Manu Chandri. Looks like maybe you're on mute.
I'm so sorry. Can you hear me now?
Yes, perfect. Thank you.
Okay, good. You figure after a year of Zoom, I wouldn't know to turn off my mute, but apparently I don't. So my name is Dr. Manu Chaudhary. I'm the president of Capital Dental. I have a very diverse background. I think this is maybe my third career. My first one, I was a process development engineer. I have a master's in bioengineering. And then I decided to become a dentist, and I practiced for a number of years in public health settings, private practice, as well as starting a free clinic as well. And I've been in my current role for the last year, and my vision for pretty much life in general is to elevate humanity. And I really believe that the integration of all things IT really needs to be at the forefront of when we talk about health and really achieving real health outcomes through an integrated fashion across all health disciplines. Really happy to be here, and thank you for allowing me to be a part of this awesome organization.
Great, and thanks for joining us. Next, we'll go to David Dorr.
Hey, thanks. My name is David Dorr. I work at Oregon Health and Science University, where I've been for just under 20 years. I'm an internal medicine provider here, working in primary care, and a researcher and an administrator. I'm actually the Chief Research Information Officer for Oregon, for OHSU. My research and education and a lot of my efforts around policy historically have focused on using data, information, and knowledge for vulnerable populations. So have a lot of experience in a number of areas, really trying to make the benefits of informatics and IT real for health, especially for at-risk or vulnerable populations. Nice to be here. Thanks.
Great, thank you. Next, Carly Vedronic.
Hey there, Carly. I'm the executive director at Project Access Now. I have a background in social policy and public health with a focus on how we develop systems to promote or inhibit health. I have quite a bit of work. I've done about a decade of work developing public health programs, evaluation, and infrastructure, both domestically and internationally. And most recently spent about 5 years directing health equity efforts with FQHCs around the state. So I have a deep soft spot for Medicaid and the populations that are seen in the health centers. I think my interest and commitment to HITOC is to really think about the integration of social determinants of health, community information, and how we're integrating that with health information, and encouraging us all to keep a focus on how communities can access their own data and use information at their fingertips. Happy to be here.
Great, thank you, and welcome. Let's see, next up we have Abdi Musay.
Yep. Hi, everybody. I'm Abdi Musay. I am informatics project manager currently working for Multnomah County. I have been with the county for the past 20 years. I have been also fortunate to have worked with, a clinic side of primary care homes, as well as public health, and also a bit of a behavioral health. So interested in basically the area of interconnectivity, interoperability, and how do we harmonize basically our technologies so that we can serve our populations better. All Oregonians basically. So my background is about computer science and technology and project management. So that is the experience that I have. I'm also interested in the education field, which is completely different. I'm currently doing my doctorate program at Lewis and Clark. Also interested in leadership and education. So I have that expertise and knowledge that I feel that I can contribute to this committee. So I'm looking forward to working with you all.
Great, thank you and welcome. And then we have Diane Schoener.
Hello, I almost said good morning. So good afternoon. I'm Diane Schoener. I'm the CIO for the Yakima Valley Farm Workers Clinic. And you think Farm Workers Clinic in Yakima, why are you on this committee? We have a number of clinics in all throughout Oregon. I work for a federally qualified health center. We provide medical, dental, behavioral health services for a good number of patients in the Oregon area. I have been working for farm workers for 24 years, implemented a couple of EHRs, developed a business intelligence team, done a variety of things from the technology leadership space. And I'm really looking forward to providing some input and helping to guide the directions when it comes to health information technology. So thank you.
Great, and thanks all the new members for introducing themselves. I should have noted earlier that in addition to approving the new members to HITOC, the Oregon Health Policy Board also renewed some of our existing members. So we will have Bill, Miley, Amy Fellows, Valerie, and Amy continuing with us as their terms got renewed as well. So let's just go around and have the existing members introduce themselves. I'll go down the list from top to bottom here just to make it a little bit easier, and we'll start with Bill.
Thanks, Eric. Bill Bard. I'm a renewed member. I've spent 3 years figuring out all of the different acronyms we use in healthcare and IT. And so now I'm looking forward to the next 3. My background is in IT. I have 35 years in the airline industry, and then 10 years as an advocate for people in long-term care. And it's from that standpoint that I feel that I'm here to represent the consumer interests in this topic. Thanks.
Thank you, Bill. Miley Bonet from Legacy couldn't be with us today, but she's an existing HITOC member. Next, we'll go to Casey.
Hi there, I'm Casey Burgess. I work for Deschutes County Public Health and Behavioral Health. I'm an existing HITOC member, just finishing up my 3-year term, as I feel a need to plug in on a more community-based level, or re-engage, I should say. I'm a clinical information systems analyst and administrator.
Great, thanks, Casey. How about Amy Fellows?
Hi, this is Amy. Sorry, I'm off camera right now because I'm not quite home yet, but I'm the executive director of We Can Do Better, which is a healthcare civic engagement organization. And I will post later. We have a couple of events coming up to kind of debrief the end of the legislative session. I also do health IT consulting for Pivot Point Consulting, primarily with federally qualified health centers. And I'm also doing a small contract right now with Lake County Public Health focused on community-based organizations and COVID response. So kind of a few different hats, and thanks.
Great. Valerie Fong from Providence also couldn't be here today, but is an existing member. Next, we have Amy Henninger.
Good afternoon, everyone. Amy Henninger, Primary Care Medical Director for Multnomah County FQHC. And I've been with HITOC, I'm not sure, like 4 or 5 years, something like that now. Thanks.
Great, thank you. Next, we have Mark Hetz. Oh, you're on mute, Mark.
Yep. A year and a half of this, and you think I'd know how to unmute as well. Mark Hetz, Executive Director for HIT Commons. We're a statewide collaborative with the OHA at the table as a partner, and then also all of the hospitals and most all of the payers across the state. And we focus on collaborative projects with an IT focus. And been doing this for 2 years. Prior to that, I was the Chief Information Officer at Asante Health System for 24 years. And prior to that, just doesn't really matter at this point. So welcome, everyone.
Great, thanks, Mark. And then we had Kellen Joseph also couldn't join today. He's from the Yellowhawk Tribal Health Center. And that's the end of the HITOC members. I'll go next to Kirsten, who's the Health Policy Board Liaison to HITOC.
Yeah, hi everyone. So happy to be here. Kirsten Isaacson. I have the pleasure of being the liaison to HITOC from the Oregon Health Policy Board, where I'm a board member. I'm also the research director for the Service Employees International Union, Local 49. We have a lot of members in the healthcare industry, and I'm active in our healthcare policy. Thanks.
Great, thank you, Kirsten. Let's see, I think we can go to the OHA staff next. I'll start with Susan, and then maybe you can go through your team, as I don't have a good list for all
Sure.
of you.
Yeah. Marissa, do you want to go to the next slide? So I think everyone, we've met. I'm Susan Otter, Director of Health IT for OHA and executive sponsor for the work of HITOC. And you can see on this slide the staff in our office that you'll be engaging with for different topics. So I'll let you review this, and actually would like to introduce Ashley Ashworth, who is new to our office as the HITOC lead analyst. And I thought we could just have Ashley introduce herself, and then I think we'll have other folks introduce themselves later in the presentation in the meeting when they're presenting. Ashley?
Hi, everyone. I'm Ashley Ashworth. I'm the new lead HITOC analyst. Most recently, I was at the Pew Charitable Trusts, where my work focused on application programming interfaces, mostly looking at patient access, clinical decision support, and provider-to-provider exchange. And then, like a lot of people during the pandemic, my work pivoted to look more at public health data infrastructure. So really looking at electronic lab reporting and case reporting, immunization reporting systems, and syndromic surveillance. I'm really looking forward to getting to work with all of you and learn about your priorities and meet you in person, since I am moving from DC to Oregon in about 30 days. So please send me your good thoughts.
Great. I think we can move on. Thanks. Welcome, Ashley.
All right, well, thanks everybody, and thanks for all the introductions. We also next have up on the agenda, I should have said at the beginning, the bulk of our agenda today is really going to be focused on strategic planning. As some of you are aware, we were supposed to update our strategic plan during 2020, as our previous plan had really expired. It was time to do that work. Obviously, with COVID going on, we suspended a lot of our meetings, and a lot of the OHA staff was busy working on COVID-related activities. And so we pushed that out and are now kind of re-picking that up. And so that's really going to be where the focus of a lot of our work will be today. And so we have a few other topics to cover and get some other updates, but that's the bulk of the agenda, as you saw. So next on the agenda is approval of the minutes from our April meeting. It's hard to believe it's been that long, but that is the last time that we met, and those minutes were available via the email that Hope sent out in advance. So if there's any comments or questions on those, we can take those, or we'll take a motion to approve the minutes. Any comments or questions on the minutes? Should we get a motion to approve the minutes? Bill looks like he made a motion to approve. Is there a second? All right. All in favor of approving the minutes?
Aye.
Raise your hand or say aye. Any opposed? None. Okay, we will approve the minutes. Next on the agenda, we try and give time to Kirsten to give an update from the Oregon Health Policy Board. So she can talk a little bit about the presentation that we recently did to them and any other updates that she has.
Yeah, great. So I'm happy to give this report. Health Policy Board just met, but at our meeting before that on July 6th, Susan and Hope presented a very brief update about what HITOC's doing, but most importantly, presented a draft membership slate to the Health Policy Board. And I'm so happy to say that that slate was approved. Want to welcome 5 new members and happy to have her returning. And I want to highlight this not only because I think it's important that HITOC kind of be at full capacity so that it can really grapple with the strategic planning ahead that is so important. But the approval was I think a recognition of the really thoughtful and intentional process that was led by Hope. And the board said had very positive things to say, and HITOC went a little early. The board they didn't go early. HITOC went on the timeline that HITOC needed to move on. But from a health policy board, we are in the midst of staff is forming, trying to be more thoughtful about committee membership and recruitment and retention recommendations for improving the diversity and inclusion of the board's committees. And so there are some promising recommendations for kind of how we make systematic change to our recruitment and processes that will improve efforts in the future. And kudos to Susan for actually leading that great work. And that just came before the board in August. So HITOC slate was approved before that. And I think it was approved because there's recognition of the great work that had been done in the recruitment and recognizing these lens, even though they went kind of early before they had the benefit of these systematic changes. So congratulations to that. Met several times with the chair and vice chair to review applicants and advise on filling the remaining gaps and ultimately select the proposed slate. The board approved it. The board definitely really appreciated that a seat remains vacant to fill additional gaps, and we hope that that can be filled by the end of the year. Staff is planning to come back to the Health Policy Board with an overview of HITOC's work, because unfortunately the agenda was kind of packed, and I think the board didn't get to really hear from HITOC and about the work that this committee is doing. And so we are having an educational webinar that will be HITOC focused, including a focus on the community information exchange, likely in October. And those happen on Tuesdays at 8 a.m. So if anybody wants to tune in, keep your ears open. And I think it's so important that the board hears from HITOC and about the work that this committee is doing, particularly as we head into waiver renewal and really identifying not only objectives in the new waiver that the state is requesting, but in implementation of the goals we put in it. And I think that items like the community information exchange will be critical tools to achieving the goals in the new waiver. So just congratulations, amazing work. It was very thoughtful and appreciate it. Thank you.
Great, thanks, Kirsten, and thanks for your support in helping us get the members approved. That was a great addition to HITOC, and we appreciate your help with that. The next topic on our agenda is a couple of HITOC leadership decisions. As people are aware, I think that we extended members as well as the chair and the vice chair roles during COVID while HITOC was largely on suspended. And so to kind of get back onto our more normal timeline, we are going to extend the chair role to go through the end of 2022, and then extend the vice chair role to go through the end of 2023. And then we we'd had a concept of trying to get to a chair-elect and a co-chair-elect as part of some updates we made. We'll try and get back onto that schedule in the middle of 2022. So we'll revisit that probably in the June timeframe. And so with that, I'm going to turn things over to Amy to facilitate the chair election process.
All right. So just to set the framework again, we are at the beginning of our HITOC strategic plan. And so our chair term will go through December of 22. And I would like to call for nominations for chair of HITOC.
Amy, this is Mark Hetz. I'd like to nominate, I don't think that we're out of COVID yet. And also with the start of the planning process, I don't think it's a really good time for us to be changing courses. So I would nominate Eric to continue on in his role and maybe jumping the gun a bit, but I would also nominate Amy that you continue on in your role as vice chair.
Thanks, Mark. People are also allowed to self-nominate. Are there any other nominations out there? So we'll need to record votes. So please, please either hold up your hand, say your name out loud, or type into the chat. And do I have a second for that nomination of Eric Doolin to remain as HITOC chair through December of 2022?
I second that.
Okay, so let's call for a vote. So please type in the chat or raise your hand. Raise your hand, thumbs up. I don't know, all the different Zoom things.
I think you should say all those in favor.
Oh, okay, thank you. I'm still figuring out the what is it, Richard's rules or?
Robert's rules.
Yeah, Robert's rules. Yeah, so all those in favor, please say aye.
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 All those opposed, please say no. So for our hope, do we have votes from everyone recorded?
Hello. Yes, I heard and saw in the chat ayes from everyone. And if you didn't say aye and I'm misrepresenting you, please let me know.
And Eric has abstained.
And Eric has abstained. Thank you. I see that in the chat.
Great, thanks, Amy.
Great, thank you. So we have elected Eric to continue as HITOC chair, and I'm going to turn it back to Eric.
Just when I thought I'd get out of this for after 10 years, but COVID threw a wrench in so many things. I'm actually really looking forward to working on the strategic plan, and I was excited about doing that last year. So I'm pleased to be able to participate and continue through that process. Just moving on to the vice chair election, I think that Mark had put forward Amy's name. Was there anyone else that wanted to self-nominate or nominate someone else for the vice chair role at this point in time? All right, well, hearing none, is there a second to for Amy's nomination to vice chair?
I second that.
Thanks, Abdi. So we'll go ahead and vote on that again. Just if you want to put it in chat, or if you want to do, you can do voting via reactions as well for electing Amy to continue as vice chair through December of 2022. All right, I think that is everybody. So thanks for doing that. That is helpful. And great that to have Amy continuing with us as we work through the strategic plan work. Next on the agenda is legislative session and budget update from Susan. And so I will turn it over to her to provide the update.
Great. All right.
Sorry, Eric, you basically covered it, but
oh yeah, go ahead.
we did have Marissa, if
Oh,
you
I'm
can go to the
sorry.
next slide.
Yeah,
That's
yeah.
okay. I'll just reintroduce myself briefly. I'm Hope Peskin-Shepherd. I'm a policy analyst in the Office of Health IT. I joined right before the pandemic in February of 2020, and I help support HITOC and some other areas. And so you'll still be hearing from me too. If you thought you had good communication before, just wait till there's two of us. Eric, you did a really good job of explaining it, but basically we were just explaining that the idea in the bylaws is that the chair and vice chair terms are 2 years. They are staggered by a year, and each is shadowed by a chair-elect or vice chair-elect for 6 months before the term ends. And at this meeting, we're not planning to appoint the chair-elect or vice chair-elect. And as you said, we will dive back into that around June. This was intended as a path for leadership development. And so if people want to start thinking about that, we will check back in on that next year. So thank you.
Thanks, Hope, and sorry for missing that agenda update there. Now we can go to Susan with legislative and budget updates.
All right, great. Let's go to the next slide. I'm actually going to hold on the health equity focus and OHA's 2030 goal. We'll actually reflect on that as we do the strategic plan update section of this meeting. But hopefully folks are tracking at a high level that OHA has a goal of eliminating health inequities by 2030 with a focus on anti-racism in particular, and that we are retooling the work that we do and our priorities to focus on the foundation of health equity. So that also is a major factor in the legislative session and budget outcomes. Next slide. So I just wanted to give you a quick overview of some of the large budget outcomes and legislative direction. The work of HITOC is really to support health system transformation in Oregon with health information technology, tools, programs, policies, information, et cetera. And so it's important for HITOC to be tracking where we are with health system transformation in our health system. Hopefully folks are aware that although last fall we expected a significant revenue shortfall for Oregon's budget this biennium, that actually turned around and we were able to see really great investments in new areas for health and other areas for our state due to the kind of surprising updated revenue projections. For folks that aren't tracking, our biennium is July of 2021 for 2 years through June of 2023. So that's our state budget cycle. So we've included a link here to the Oregon Health Authority's end of session report. A couple quick things. The OHA's service level was fully funded, including the Oregon Health Plan. So that means that our services and programs that we have had in our last biennium received full funding. That included some increase in state general funds to maintain that current service level due to increased forecasting and other things of folks needing to access services. There are additional incredible investments also in this legislative session focused in health equity, behavioral health, and public health. And the end of session report really goes through a lot of those investments. I wanted to highlight a few things for you though. Next slide. So some of the new direction from the legislative session for health system transformation includes these areas that I'm kind of pulling out. There's a lot of great new investments, and I just wanted to highlight a few things. So universal coverage was a huge priority this session. The goal is to move from 94% to 98% of Oregon's population covered by health insurance. There are several tools to do that. One is our Medicaid 1115 waiver, which we'll be having a presentation on next in this meeting. So some of those changes are meant to increase and support coverage on the Oregon Health Plan. There's also a public option health plan bill that passed, and a bill to cover all people. Cover all people is really meant to support individuals who lack insurance or ineligible due to their immigration status. And so that's a very exciting bill and investment to be able to extend insurance coverage to folks that have traditionally been left out. So that's a huge new bodies of work in OHA to support those pieces. The second area is a real commitment to cost containment in our healthcare system. As folks probably have known, if we have a lot of waste and duplication in costs in our healthcare system nationally in the United States. We have done a lot to try and address that. It can be a barrier to care for individuals. You may have health insurance coverage, but still not be able to access care if the premiums or copays are too high, for example. And so there's a number of new efforts that was passed this legislative session, and this will also be a focus of the Health Policy Board. One is the Value-Based Payment Compact, which is a voluntary agreement across health insurance payers in Oregon to support moving to value-based payment and some alignments there. And that work has been moving forward, and we're excited to see a huge group of payers already committing to that work. Secondly, mergers and acquisitions for healthcare organizations now require review by community members. So that's a new component as well. And then the third area I wanted to highlight was behavioral health. So we saw unprecedented new investments in behavioral health in Oregon, including new funding for treatment and housing, incentives to support workforce, and particularly a culturally and linguistically appropriate behavioral health workforce in Oregon. So a new behavioral health workforce incentives program. And then a new accountability program looking at behavioral health, setting up behavioral health metrics and accountability to oversee some of this work and hold our systems accountable. That work will report up to the Health Policy Board as a new committee, and will be informed by individuals with lived experience, community groups and members and providers. So that is also an exciting development for behavioral health. And then lastly, I didn't want to forget to mention that there was a telehealth bill that passed that expands coverage and reimbursement for telehealth services in Oregon. We saw a lot of advancement in telehealth policy, and through the COVID pandemic, there was a lot of temporary changes made to allow telehealth to be more policies to be more flexible about reimbursement or coverage. And some of that was, made permanent in the legislative session. Next slide. So I wanted to talk about our Office of Health IT budget in particular, as folks have been tracking, at least on HITOC. We have a major transition in our budget this year. Before I do that, let me go back and see if there are any comments or questions, or Kirsten, anything you wanted to add around the overall kind of legislative direction and really incredible policy and investments that came out of this legislative session.
No, I think you summarized it great.
Anything else? Any folks had questions or things? I think we want to be thinking particularly about this new direction and these as priorities, and how health IT can support things like cost containment, behavioral health, telehealth, health equity, coverage, if possible, those sorts of things. So we want to make sure that we're really tuned into these as priorities. Okay, well, let me talk a little bit about our budget.
Can I interrupt?
Yeah, no,
one
go
thing,
ahead.
Susan? I would add that I think those priorities really reflect the priorities of the board too. There was a lot of overlap between what came out of the legislative session and priorities that had been identified, that have been on the board's priority work plate. And so I think recognizing that those are the priorities is important. And so if people do have questions about them, like we should wrestle with it, because I think we will be saying like how is the work of HITOC fitting into those priorities, and and I think it's important that like we can't achieve the work that needs to be done without lots of work. So HITOC has important tools to offer.
Great. We'll be talking more in depth about some of those priorities with the waiver presentation that's coming up next, and some of our initial thoughts about how Health IT directly supports those priorities, but want to make sure that folks are starting to process and think through some of these as well. All right. So I'm going to turn to the Office of Health IT budget. So for folks that have been tracking, or maybe have not been tracking, we've been leveraging federal HITEC Act funding that was awarded to all states in 2009, primarily for supporting EHR adoption and health information exchange across all states. And part of that funding included support for state activities that are needed to support providers meeting federal meaningful use requirements for their electronic health records. The meaningful use program includes incentive payments to hospitals and providers who can meet those requirements, and have been in place since about 2011. Those incentive payments all wrap up this year. And so with that wrap up, the federal HITEC funding for states also wraps up and sunsets. And that will be primarily sunsetting by the end of September of this year. What that means is this is a budget transition we've anticipated for 10 years, knowing that this will be sunsetting and all states are going through the same transition. But we needed to make the case for continuing our programs and the new general fund, state funds that would be needed to match lower levels of federal funds going forward for this biennium budget. So overall, what it means is we have some programs that are ending because naturally they'll be ending due to the HITEC program ending. We also have less federal funding for our work. So programs that are ending or transitioning this year, the first is the Medicaid Electronic Health Record Incentive Program. Those are those meaningful use payments to providers. Those payments all need to be made by the end of December. And so those will be wrapping up this year. We've been supporting onboarding to the Reliance Health Information Exchange through HITEC Act funding for Medicaid clinics and hospitals being able to leverage that HITEC funding. And so that program, we did get a little additional funding to continue the last 3 months of the HITEC funding. So that will end in September. We have, I think folks saw our email, we had our Oregon Provider Directory and Clinical Quality Metrics Registry technology platforms that we had launched in 2019. Both of those had been on hold this last year for different reasons. And the funding was not included in the budget to continue those programs. So we have folded those programs, and those ended at the end of June. What we're doing as staff, as a side note, is pulling together some lessons learned from those programs and other efforts that we've been successful in, and where we've had programs that have closed over time, and we plan to bring that lessons learned back to HITOC as HITOC looks at strategies for our next update, strategic plan update. And then the last piece that's transitioning for folks that are tracking, we have a common physician credentialing form that's required in Oregon under the Advisory Committee on Physician Credentialing Information. We had been managing that program in our Office of Health IT, and that is transitioning to a different office within Health Policy and Analytics Division. So as you can see, our work is getting smaller in our Office of Health IT in particular. Next slide.
Hey, Susan.
Yeah,
Looks like Diane has a question.
sure, go ahead.
Yeah, thank you. On the last slide, do you see a problem in the future when you talk about like interoperability, health information exchange? Do you see a problem in that the Oregon Provider Directory is ending? Or I'm not sure what it means it ended in June. So that means the directory goes away. And all the work that went into that development, which might need to come back again in the future when you talk about the other programs. So I just a little concerned about that.
Yep, I am concerned about that as well. The provider directory was a core component of our strategic plan as kind of base infrastructure for health IT in Oregon. There have been a few things that have evolved since we put the provider directory in the strategic plan nationally that have made sharing provider data across organizations more available or built into the workflows. So I think the needs have evolved. So that's something that we'll be looking at as we look at our strategic plan. But it had been a core component of what we were expecting to have in our infrastructure, and we'll need to adjust without it. Any other questions before we move to what's continuing? Okay, next slide. So the work that is continuing, we are wrapping up the last of our HITOC Act program funded work. We'll have additional wrap up and reporting to CMS on the Medicaid EHR incentive program. There's an audit component that will continue on through into 2023 to really close out that program. So payments will all be completed by the end of this year, but then they'll be reporting and audits. And then CMS expects all states to submit a final state Medicaid HIT plan and environmental scan by May of next year. That gives us a great opportunity to continue to leverage that 90% HITOC Act funding for the staff work and support needed to produce those two documents. The state Medicaid HIT plan really will overlap a lot with the strategic plan work that we're doing. And then the environmental scan looking at EHR adoption and HIE adoption is work that we're continuing as well this year, and particularly focusing on a CCO survey, getting at adoption across CCO contracted physical, behavioral, and oral health providers. So we'll have a little bit of wrap up going on with the HITOC Act that we can leverage for other broader purposes. Our policy work will always continue, HITOC, and any subcommittees, strategic plan update. We're excited about the opportunities with community information exchange. And we'll be talking more about that as we get into the strategic plan update kickoff later in this meeting. We'll continue to play a role in policy, environmental scan, and we do a lot of work internally within OHA and ODHS to coordinate around health IT. So our staff work will continue in those areas. The new federal interoperability rules will continue the work that we're doing around supporting stakeholders and with that effort. And then some new work that's come out of the legislative session I'll talk about in more depth around race, ethnicity, language, disability, and sexual orientation, gender identity, data that will be newly required, and other areas where we can support health equity goals around health IT. Next slide. As I mentioned, we do oversee CCOs and their health IT efforts. CCOs are required to submit a roadmap each year, an updated roadmap each year on how they're supporting electronic health record adoption, health information exchange, and value-based payment for their members and for their providers. So we'll continue that work. I mentioned the survey we'll be doing and supporting to support collecting more thorough data on EHR adoption and HIE use by CCOs contracted clinics. And then we convene a CCO advisory group to help support CCOs and get their input on our work. And then lastly, the work will be continuing with the HIT Commons. I think Mark mentioned a little bit about the Commons being our public-private partnership that OHA co-sponsors. And the work under the Commons, we play a role in supporting financially and with some staff support as well. And you can see some of that work here. I want to highlight the public health data sharing work group, which has really come out of this last COVID data sharing efforts. And I think will be a really good group to inform HITOC on our strategic plan work and opportunities to connect with public health, as well as a payer interoperability collaborative, looking at how we can support the federal interoperability rules and requirements that are falling on Medicaid and Medicare payers. So hopefully that was a little bit of a taste of, an overview of the work we have continuing. Our office will be getting smaller. I just want to flag my role is being split. I'm starting to work on special projects away from health IT as our role is getting a little smaller. So I think our strategic plan work will be really important to help look at what is the need moving forward, where do we have opportunities, and help us make the case to where we need new investments or to shift our priorities. Let's go to the next slide. I'm not going to go into our funding. This is the funding that we received to continue the work that I just mentioned. Next slide. I mentioned the COVID data sharing. So we were excited that a bill passed that allowed OHA to share COVID case data with CCOs and payers through the collective platform and Reliance. And that is, we're using that as a case study for the public health data sharing work group that I mentioned to learn lessons about how we might be leveraging this kind of partnership with public health going forward. Next slide. And then the other House Bill 3159 is what I was starting to talk about. This bill requires a new collection of from providers and health insurers data from their patients, clients, or members on race, ethnicity, language and disability status, and sexual orientation and gender identity. These are Oregon-specific standards that have been in place for we call that Real D for a while. And this is really rolling out a broader use of collecting data on that can help us understand our populations and our health equity efforts. A component of this is that OHA will be required to establish a data system to receive and store these data, and a path for patients to be able to submit their data directly. So a provider or insurer could point a patient to the registry or data system and to submit the data directly. So we did get one staff person to help from the bring the HIT perspective to the work. There's a huge investment in staff for the Division of Equity and Inclusion and our IT shop as well to really launch and support this important work. Next slide. There was one bill that we had been talking about that would have directed HITOC to provide specific recommendations in our strategic plan update, make those recommendations to the legislature. That bill did not pass, but we're reflecting on the requirements in that bill as we design the strategic plan update work. And we're excited to potentially have legislative interest or sponsors for the work that we're doing. So I'm going to stop there and see if there are any comments or questions.
Go ahead, Dave.
Yeah, so thank you, Susan. This is really helpful as we start strategic planning. I note in the HIT Common, there's a payer-only interoperability collaborative sort of group. And as we especially move through this agenda, when we think about a community information exchange and health information exchange and patient having information that they can direct, can you talk a little bit about why that was payers only or focus on payers and what that group is working on, or direct us to where we can sort of figure that out?
I think Mark
Sure.
will take that question.
Okay. The specific focus of that, and we actually have Justin Keller here, who is leading that work for HIT Commons, was really in response to the federal regulations around requiring payer-to-payer exchange. So we're looking at those specific requirements there. I think that as we move forward with working with Susan's team on the public public health data sharing, we are going to be looking at HIE, CIE, and such, and looking at a much broader picture. But the specific focus of the collaborative was around a couple of specific regulations that were focused on payers. Justin, do you have anything to elaborate on that?
No, I think you said it, Mark. I think it was a targeted focus for understanding how payers are grappling and meeting the requirements from CMS and ONC around interoperability around patient access APIs and payer-to-payer data exchange. So I think it's a more focused effort of what is the bigger question, David, around kind of the payer's role in interoperability and all the exchange efforts that we're trying to make more broadly.
Any other questions for Susan before we move to our next topic? Great, thanks, Susan, for the update. That's great. Our next topic is to get an update on the Medicaid waiver and the HIT implications of that. And so Lori Coiner, who's the Senior Medicaid Policy Advisor for OHA, has joined us. Hello, Lori, good to see you. And I will turn it over to you for the update.
Great. First off, I want to say thanks for inviting me. I know lots of you from various points in my career, so nice to see everybody. Yeah, I am here to give you a waiver update, and then hopefully there will be some time at the end just to have some conversation about the potential IT implications of what we're proposing. So what I'm going to do is kind of give some broad brush strokes about where we are and some of the big policy areas that we're looking at, and then dive a little deeper into 2 of the 4 policy areas that have the most potentially biggest impact on health information exchange and IT issues, and then kind of have time for us to talk about that at the end. So I am going to ask to have my next slide. Great. So as I mentioned, there are 4 big policy goals that we have, and they sit underneath an overarching goal to advance health equity among our Medicaid Oregon Health Plan members. And this is in keeping with the Oregon Health Authority's strategic goal of eliminating health inequities by, in 10 years, by 2032. Or 2030, sorry. And so we took a look at lots of feedback that we've been receiving from community over the last couple of years through COVID, through our SHIP process that happened in public health, and numerous documents, and distilled the information that was obtained in terms of feedback and around direction and where we need to go and how to impact health equity. And this coalesced into these 4 big policy areas. The first one is maximizing Oregon Health Plan coverage. So we learned a lot about coverage, particularly during the pandemic. And so we want to incorporate some of the lessons learned through that. I can talk a little bit more at a high level. This is paired up with a potential of applying for what's called the 1332 waiver that would make changes to the marketplace with our goal of having coverage for 98% of Oregonians kind of at the end of that. In terms of OHP coverage, we're looking at things like 5-year continuous coverage for kids. Generally, kids, families meet the income requirements longer than just 1 year at a time. And it's really important for kids to have that continuity of care, particularly, you know, younger kids so in those first early years of life. Another piece that we are examining is self-attestation for income. That was established as part of the public health emergency so people could enroll faster. We're going to continue that. We're hoping to continue that. People who are interested in eligibility for the Oregon Health Plan can apply much more quickly. We've learned from our community partners that then they have an opportunity to talk to individuals about how to access care once they get it and things like that, instead of spending hours trying to, you know, get pay stubs and the like. And the income verification can be done on the back end and then followed up later if they're, you know, we don't have records through our state systems. The third part on the coverage that I'll mention is we've added about 300,000 Oregonians onto the Oregon Health Plan since the beginning of the pandemic. So we're at about 1.3 million, a little more. Most of those individuals that are on were on Medicaid sometime within the last two years. We have some new enrollees and we have some, you know, long-term returning, but for the most part, it's people who have been on within 2 years, which tells us we're capturing that churn what we call the churn population that, you know, gets eligible, then drops, maybe goes to marketplace, maybe is uninsured for a while and then comes back. And so we want to look at that population and see how we can combine with the marketplace to keep people on so that they aren't experiencing churn. So that's that piece. The second big policy area is stabilizing transitions to minimize disruptions in care. And I'm going to talk more at length on that one here coming up. So that's all I'm going to say about it right now. The third big policy area is encouraging smart, flexible spending for health equity. This includes another run at what we've called in the past, the global budget. We're rethinking that language and really thinking about it as a value-based budget so that CCOs have more of an ability to invest in health equity and social determinants of health. And then also we are making a pitch to the federal government that if it's a value-based budget and we and our state brings savings to the federal government, then we want to share in some of those savings, much like you know, a value-based payment arrangement that CCOs have with providers. And that leads me to the last, which is targeted health equity investments. This is what we would do with those extra federal dollars that we obtain through shared savings, is really target investments to improve health equity. And these would be community driven. And I'm going to take some time to talk about that as well, because we believe that there's a real role for a community IT solution to help better connect community organizations and CBOs to the health system. Next slide. So here's our overall timeline for the waiver. We've been involved in public engagement since, I don't know, April or May. We've had, what do I want to say, issued or released draft concept papers. You may have seen them in June, received more public engagement across June and July, and then are revising those concept papers based on public feedback. We anticipate having those out again for review in the next 2 to 3 weeks. And then those will inform our application, which will be submitted in December. Negotiations with CMS will start in earnest right after the application submission, and the target approval is the end of June of 2022. Next slide. So here's some, I guess, more recent milestones. We did have a meeting with the demonstration group of the Center for Medicare and Medicaid Services, just to talk about when we're going to be submitting concept papers, confirm when we submit our application and that sort of thing. We meet next week with the new CMCS administrator, so the new person who is overseeing the Medicaid program. I think we're really fortunate. He moved from being the Medicaid director in the state of Massachusetts to this role. I know him really quite well. He's very bright, comes from Massachusetts, which is a progressive state, which incidentally is working on a waiver that has many of the components that we do right now. So we meet with him and his leadership next Tuesday. In August, we also have tribal consultation beginning. However, I do want to say we've been talking and working with tribes on requests around the waiver since April or so. And then, as I mentioned, the policy concept papers will be finalized. We're committed to translating them in multiple languages, and then they'll be released publicly. And then public comment will continue across the fall. Next slide. So here I'm going to take some time to talk about stabilizing transitions to minimize disruptions in care. And let's just jump to the next slide. We'll talk a little bit about what that is. So one of the things that we know is that there are, what do I want to say? There are times that our members experience care where they're moving from one system to the next. And that tends to be a place where we have gaps in services, gaps in coverage, and it's also a time when there's a high need for to meet those members' social needs. And so we really are focusing on those kinds of situations. So what do I mean by that? We're talking about people who are leaving the criminal justice system, for example. We're also talking about folks who enter county jails. So, and I think you'll appreciate these kinds of issues. So someone enters a county jail and they have a chronic condition and a substance use disorder. When they walk in the door, the county jail has, their health system has no connection to the outside health system at all. So don't know the underlying condition of that person, don't know any meds they're on, don't know that they have a substance use disorder or whether it's being treated or not. And so we're asking for coverage until those individuals are adjudicated, so that there can be a connection and that there can be an opportunity to have information about that individual's health care come with them. And then on the back end, when they're leaving jail or prison or youth authority, we're asking for 90 days of coverage prior, so that, and that wouldn't be a full Medicaid benefit. We're not asking to, have the feds offload our expenditures for that, but instead cover care so that those members can have a navigator, preferably a traditional health worker or community health worker or a peer support person who knows kind of what they're up against and their culture. And then start to find housing supports and services, meet other social needs, employment services, or whatever they're going to need to be successful when they leave. Also, make appointments with their doctors, walk out of the facility with 30 days of meds in their hands. So those kinds of things, so that there is a better transition from one system to the next. So the goals of this are to really focus on integration of care, focus on having that care be culturally and language appropriate for the person, and keep enrollment preserved as much as possible as people move between these kinds of systems. Next slide. So basic problem. Our health system is complicated, and it's especially complicated when there are big transitions. So we're going to talk a little bit more about what transitions are included. Next slide. So one is homelessness or risk of being homeless. We're considering that a transition or a life transition where people may not necessarily lose their Medicaid coverage, but they certainly are undergoing a real increase in social need help. So and what we're doing on the, I guess, social needs side is if a member is homeless, then they would qualify for a package of benefits around housing supports and services. They might also qualify for food assistance. They might qualify for having, in all cases of these transitions, we're really thinking about navigators and peer supports. And like I said, traditional health workers. So there is a piece in the waiver that also talks about building that workforce and allowing Medicaid dollars to pay for that workforce, even if there's not the kinds of clinical oversight that that's typically required. Next slide. I already talked about incarceration. So this would be people leaving both jails and prisons. I will say California is making a similar ask. Their waiver was submitted in June, and I believe Massachusetts is as well, though theirs is even broader reaching. So, and again, these individuals would qualify for, a series of social needs. And for those of you that are aware of our health-related services, I think the way to think about it is instead of having to have a CCO approve a specific health-related service every time a person needs it, these we're thinking more in terms of in lieu of services. So saying it's almost like a benefit that if you're in this transition, you would qualify for these sets of services, and there isn't, and that's really to alleviate the administrative burden of trying to do a one-off health-related service every time, and also to eliminate and to increase the use of health-related services. Next slide. We're also looking at folks in state hospital, other mental health residential, and substance use disorder residential services. The individuals who are leaving any of those institutions are facing similar issues around social need help, and then also coverage for the 90 days before a person leaves state hospital. Next slide. Also foster youth, foster kids who are either aging out of foster care or going home to parents. The kids and families have special needs that we want to make sure that are addressed. That can be things like ensuring parents have peer supports if they've undergone recent SUD treatment, supports for kids, making sure that the family has stable housing and that sort of thing. Next slide. So I'm going to pause there and see if anybody has questions on that topic before I go into the other policy framework. Thoughts or questions?
I do, Lori. This is Carly Hodronic. I really appreciate seeing the investment in a lot, or the intended investment in a lot of upstream needs and supporting individuals that are leaving a variety of scenarios where they've been supported. It does make me think that the need for data exchange and support across all these systems is even more imperative to make sure that individuals have a record following them that can help them interact with a variety of different people supporting them. So I think hearing that this is a state strategy and a potential federal strategy is really important for all of us as we look at our strategic direction. So just a thought and comment.
No, I think you're right on that, and we have started to think and had some conversations with Susan's team about mostly around, a community information exchange. But I do think when you're talking about these systems, it makes a difference. And I know, for example, and I apologize because I can't remember what states, but there are a few states who've had kind of personal health records go with foster kids. So because the same thing happens for them, they enter the foster system, and in our state, they often have to leave their area. I mean, if it's Portland, that might not be true, but in other parts of the state, they may go to a totally different CCO or a different health system. And again, the health system doesn't have information. And one of the things that we've heard, there are some kids, the most troubled kids bounce a lot. So they may be at one home and then they need other kind of services and they move somewhere else, and they have to go through their whole assessments every time. And it's really traumatic for the kid. So, that's been something that we've talked about with the Child Welfare Director, Rebecca Jones-Gaston, about, because, if we could come up with some kind of personal IT solution, that would be fantastic. So anyway, I think it does bring up a host of issues that be happy to talk more about or strategize with this group. So I'm going to talk a little bit about the reinvestment in savings in communities next. So if we can move to the next slide. Now I am going to say that this is, contingent on us receiving additional federal dollars to some degree. There is a House Bill 3353 that just passed, does require CCOs to invest 3% of their global budgets in health equity. And a percentage of those, 30% of those dollars, so about 1% of their budget, would go to community investments. And we're calling that in our waiver community managed funds. So that would happen regardless. We're also asking for some additional funding from the federal government to help build a lot of infrastructure for community-based organizations, provide technical assistance and other kinds of supports so that they can be successful in helping administer funding and initiatives. We have heard in lots of our public engagement, that there's a real desire to have decision-making power go back to the impacted communities along with resources. So really both the ability to make decisions and have some funding behind those decisions. And that's our belief that will really move our health equity goals forward. The other thing is, we know that there's lots of problems that span a larger, span across the state. So things like that are, for example, a culturally appropriate workforce, particularly in behavioral health. That's an issue that's not unique to one area, that seems to, there are some things that might be better solved across the state as opposed to having each CCO figure it out. Next slide. We've been meeting regularly on the community managed funds piece with the regional health equity coalitions, and so they've had regular meetings, I think about 12 meetings actually, with OHA staff to kind of create this model. And there were some principles that were established between the groups, between the RHEX and OHA, in terms of how we see work moving forward. And so these are those principles, and that's really targeting investments to populations that are most impacted by health inequities. That's defined really as tribes, African-American and Black community, Latinx communities, Asian, Pacific Islander, American Indian, Alaska Native. So the real focus is on what we call in the waiver priority populations, but those that have been most impacted. Then shift that power and decision-making to the community and create opportunities to build the sustainable infrastructure. So and that's where some of the funding needs to go. And I think that, you know, the middle box there is really where we need to think about the IT, because if we're going to be successful in, you know, building sustainable infrastructure, that will include a need to exchange information. Support community leadership development, and then, you know, continue to build and rebuild trust between the health systems and community so that we work more closely together. Next slide.
Oh, yeah, I have a quick question. Sorry. Yeah.
Oh yeah. No problem.
Yeah. I'm just thinking in terms of, I mean, you raised an interesting point around, you know, investing in community, but the investing in community also requires having structure in place. Technology, speaking technologically, a classic example here is about broadband technology, where individuals and communities would have a full access to their, you know, medical record, or where they can pull, you know, an X-ray, for example, right? You don't want to have a 2 GB based internet where individuals cannot even pull out anything, or even cannot even, you know, view anything. So has anyone paid attention to that as well in terms of investing in infrastructure through broadband that is basically capable of basically having that information shared basically individually and also community, you know, at large as well?
And you bring up a good point, and I don't know, Susan, we haven't really, you know, we've been talking about a community information exchange, but I think the broadband issue, particularly in parts of Oregon, is a critical one to include in discussion. And in the interest of time, I'm going to breeze through the next 4 slides so we have a little bit more time for discussion. And I think I covered this, you know, really that we want to reinvest savings into community and partner with those communities to identify what strategies are going to be best engaged to eliminate health inequities. Next slide. So hopefully we'll convince the federal government that we have some savings and they'll send us some extra dollars our way. Next step, or next slide. And then, like I said, there's going to be a need to build capacity. We've heard from CCOs that, you know, they've really had to invest to have community organizations have the infrastructure to handle finances and so forth. And so we're committed to trying to make investments in building leadership and kind of administrative supports to make this happen. Next slide. And the idea is to create these community collaboratives. They will be self-identified. They'll pick their own region and then apply for infrastructure money, you know, to build the collaborative. And then what we're hoping is if we do get federal dollars, that then we would create opportunities for grants. And the kinds of investments that could be made would be, you know, to build a culturally responsive workforce, increase outdoor opportunities for green space, housing and housing related services, or, you know, potentially, you know, having childcare in low income housing, for example. So those are just some of the examples of the kinds of investments that could be made. Next slide. And that, you know, the goal is really to give these community collaboratives. I do want to say before we move on to discussion that the community collaboratives have a lead organization that needs to come from the community. It could be a regional health equity coalition. It could be another organization. But the CCOs, local CCOs, hospitals, public health, and other, you know, parts of the health system need to be at the table as well. So we really see these as collaborative efforts, and we also see that the investments that would be made need to have a framework around, you know, looking at the local community health improvement plans and those sorts of things, so that it's a combined effort. We also would have the CCO community advisory councils would be included as well. Next slide. So let's connect the dots for IT, and we can jump to the next slide and then have some discussion. So the waiver team, we see, you know, health IT has the potential to provide a foundational infrastructure for some of these concepts and in moving health equity. So I think I'm going to let you kind of look through these, see if we have it right, or if we're missing something. We have had discussions about whether, you know, some of the federal dollars could go to help support IT, or whether we can get a better match, you know, through our regular process. So we're looking at that. But I really think this is an opportunity to hear from you about, you know, are we thinking about the right things in terms of how health IT might support our waiver. And Susan, I don't know if you want to moderate or if you have thoughts.
Sure. I think we threw on this slide the things that we've been discussing, where, you know, health information exchange and community information exchange are critical in those transitions of care. And there's other ways we use data analytics around cost containment, health equity data, et cetera, and supporting behavioral health. But we wanted to hear from you. What comes to your mind as you're hearing from Lori about the priorities in the waiver and how health IT can support this work?
So this is Manu. Can everyone hear me? Okay, yeah. Perfect, thank you. So I normally don't like talking first, but it was kind of silent, so I'm going to go ahead and say a few words. First, I want to say that I really appreciate your time, Lori, and all of your effort with bringing this and kind of sharing this on a very frequent basis. I sat in on a work group what feels like maybe a month or two ago, and I really like how these things are developing, kind of moving forward, and kind of not really seeing the concept papers as written in stone initially, but kind of seeing it as an evolution into something greater. And so from the start, thank you for making this an evolutionary kind of concept of bringing forward over the next 5 years. One of the things that really kind of speaks to me a little bit is regarding the concepts of the universal health record. There was a case that came in, but rather in my role, I oversee a capital dental care, which is a dental plan. And one of our member services team fielded a call that resulted in the patient threatening suicide. And we had to call, 911 and get everyone involved. And thinking about what those steps are if that patient were to were to reach out to maybe another dental plan or reach out to the CCO, and it might be a first time experience for the organization that tries to help this particular member. But by having a universal health record that's tied directly to the member, then we can ensure that all levels of care are being provided in order to help, just to help heal that member in the very moment that it occurs, not wait till it's the 10th time that that member has tried reaching out, or so on and so forth. The second point that I want to bring up is that I'm a very strong believer of the quadruple aim. I've believed it, I've spoken about it maybe over the last 8 years or so. And a lot of the efforts of the concept papers for the Medicaid waiver are moving towards member equity across all cultural barriers and breaking things down. But I'm very concerned about where the providers are and ensuring that the providers remain their health as well. One of the views that I have of what we do is ultimately to create healthier Oregonians. And when I think of that, I don't think of just the members, I think of the providers as well, and what would it take in order to drive that. So I'm still considering exactly how we can involve that and integrate that. And if I think of anything, I'll be sure to reach out. But it's something that's very important for me, that as myself, I've stepped into the role as an OHC Medicaid dental provider, and it's very challenging to care for members on a very frequent basis. It's tiring, it's exhausting, and I feel as though in order to grow and continue growing, we need to have more providers that are at the table and are that continue with providing care to not only basically effectively to all Oregonians, regardless of payer type. Thank you.
Great, thank you for that.
Yeah, thanks. This was a great presentation. I agree. You've really, these concepts are wonderful. I want to suggest two things here that I don't see in this slide. I think you're thinking about them, so I don't know that it's right there. One is that many of the new interoperability rules are giving really the power to the individual, allowing them with no extra effort to have access to their own health information. And that's incredibly important for us to think about what the meaning and potential benefit of that is. And I think perhaps what are some issues with that we may want to think about, for privacy, confidentiality, and really how can it be most useful. So that's one thing, really. This, the community, I think, is a good, proxy for that. But we also, I think, the individual, how can their health be improved? How can inequities be addressed by empowering them to get their own information, and what could they be doing with it? And along that lines, I mean, maybe that relates in some way to a universal health record concept, which is particularly tricky in my opinion, but does get at some of the concepts where you could exchange this information in a meaningful way. And that's the other part here. The last is about interoperability. We can share data, but we really need to think about what data and how and when it matters most for health and well-being. I think that part is a crucial consideration as we move forward. CIE here, I think, sort of addresses part of that, right? That we have a gap in exchanging information for community resources, especially back and forth. And so that's a great topic. There is a lot maybe in that as well, where, health concerns, personal preferences, other issues need to be incorporated. And I'd suggest we might want to broaden that sense of interoperability to, or maybe focus it for, where are the areas where we really need, that could really improve health most, and how can we focus our HIT efforts in that? So that's mainly what I wanted to say. Thanks.
Thanks, Dave.
This is Diane. I too thank you. This is really great. It's really great stuff. I didn't want to talk too much about interoperability. That's definitely an area for me, and an area of focus. A couple of things that kind of fit around this. I'm thinking about, where does dental come in? I see under interoperability, we're talking about behavioral health, but it's to me, it's greater than that. It also includes dental. It might include, you spoke about children earlier and coverage for 5 years, but it's more than, in my mind, more than just the medical piece of it. It includes WIC and other services. So, maybe that fits into here somewhere. I just didn't hear it. When I think about the CIE, and it's that definitely that closed loop, the way that I read that wording, it's really just how do we get connected to them? It's not how do we get that information back, and how do we ensure that that interaction happened? How do we ensure that happened? Not just that we made it and then we got something back. How can we make sure it happens? So that's it for me. Thank you.
Yeah, that's great. And on the kid side, we don't have the ability in the waiver, to expand the things like WIC. I will give you an aside, but we are working, Medicaid's working on, now that the one system is up, is seeing if we can do redeterminations at the same time for SNAP and Medicaid. Wouldn't that be shocking? But I'm being a little glib, but it's not easy from the IT perspective, but it makes tons of sense from a member perspective. So we're working on that, and I think we have to ask for some additional dollars because of you have to wait for people to catch up and stuff. But I hear you on that, so that at least members could apply for everything at once at the same time and not have to do it at scattered times. So appreciate that comment.
Great. We probably need to move on to our next agenda topic, but I would like to ask one question of you, Lori, before you leave. What are your thoughts about what HITOC could do to really help build a broader understanding of how HIT can contribute to the success of Medicaid in Oregon?
That's a good question. I think if we stay engaged both through Susan and through this group, we're certainly, we will, we can send this group when the concept papers are released here in the next couple of weeks, and definitely would appreciate any kind of feedback you want to give. And then I think, continued conversations in terms of what the real needs are and how much we might accomplish some of them would be fantastic.
Right.
And I think I would just add, I think CIE just continues to come up as a priority. And you'll see when we get into our strategic plan update kickoff, we're proposing that we really kick that body of work off right away so that we can get to some recommendations around how we can leverage state actions, or if we are lucky enough to get some funding or some of those sorts of things to accelerate this work. And I think there's some urgency given the timeline of the waiver potentially to have some of that.
Definitely agree on that. And we've heard pretty big from across our stakeholders in Oregon that CIE is a need if we're going to make this happen. So, well, thank you everyone for your time. I appreciate it and happy to come back.
Great. Thank you, Lori. We are a bit behind. I think we can make up some of the time, but I think we'll try and take an abbreviated break. So we're going to take a 5-minute break if people can make a quick run and then get back at 10 after. We'll get back started and have Karen take us into the strategic plan update. we will give people just a minute more to get back. Looks like we're still missing a few.
While we're doing this, can you all hear me okay?
Yep.
Yes.
It's hard enough to herd everybody back to the table when we're all in person. It's even harder on Zoom to know when we get everybody back. Well, it looks like we've got quite a few people back. Hopefully those that we're not seeing are on mute and listening along here as we jump back into things. The next section, as I said, we're going to spend a significant chunk of time on the strategic plan update kickoff. And I think that the context that Lori set was actually really helpful. And I'm glad we were able to spend a little bit of extra time with Lori's. I think that was useful information. Maybe just add a couple of comments before I turn it over to Karen. You know, and I think back 2 years ago to 2019, when we were heading into doing the strategic plan update, it seemed like there was quite a few changes, but, you know, things may have stayed largely the same with some big influences. And when I look at the amount of things that have changed over the last 2 years, it's kind of amazing to think about how differently we need to really think about our strategic plan and what's important to us. As the state has really increased the focus on health equity and social determinants of health. When I look at the changes from a federal level with interoperability, when I look at the opportunities that have presented themselves through COVID-19, and just seeing how even in the last year and a half, some of the HIE and HIT capabilities have been helpful, and how they could have been even more helpful if we were further down the road. So I just think that this is really a great opportunity for us to really step back and not just look at this as a sort of a tweak to our existing plan or make some small adjustments, but really to fundamentally rethink about what's important and how do we get things done. I think we've had some learnings in terms of where are we successful with things and sort of who doing what is successful with different HIT programs. So I think there's just a whole lot that goes into this, and it's a great opportunity. I look forward to working with everybody to move that forward. So with that, I will turn it over to Karen.
Thanks, Eric. Good afternoon, everybody. So today, Marissa, if you can go to the next slide, please. And actually, I should probably introduce myself. It's been a little while since I've been at HITOC. I'm Karen Hale. I'm the lead certified EHR technology and HIT policy analyst in the Office of Health IT. The agenda for today, we're going to launch, this is really the launch of the good HITOC work to really start off the strategic plan again. The agenda for the conversation is really structured in a way so that we're providing the context for the work and our proposed process to update the strategic plan, and then leave a lot of space for a robust discussion and breakout sessions with this group. At the end of the meeting today, we really want HITOC to be oriented to the work ahead and hear back from you on what we have planned so far. So first, though, I'm going to turn it over to Eric to lead off with a conversation about health equity. So next slide, and Eric.
Yeah, it's kind of interesting. You can go to the next slide. I think that one of the things that really struck me when I agreed to talk about these slides is I didn't really have the context of everything that was leading up to it in the meeting today. And I almost feel like we don't need to spend as much time on this, because if I look at the comments that Kirsten made about the importance of health equity for the Health Policy Board and how that's really risen and taken a more prominent stand over the past probably couple of years. When I listened to what Lori came and shared about the waiver and some of the goals they're trying to achieve there, I think that in some respects this is all very clear. But just to reiterate some of what we had actually heard earlier, OHA has set the strategic goal to eliminate health inequities by 2030 and establish this core value on really considering diversity of Oregon's communities as we make decisions about how policy and practice are developed and how resources are distributed. This really is an important area. And I think that when you look at some of the things we've seen, particularly over the last year with COVID-19, it's really just almost put an exclamation mark on the importance of this work. And some of the outcomes there, I think, have just really provided some dramatic examples of the importance of moving this forward. So I think this really needs to just continue to be a big area of focus for us as we work on our strategic plan, and we need to bring it into all aspects as we are working through that. The next slide, for those of you that have been on HITOC for a while, we've seen the work that's got on to define health equity. You can go to the next slide, Hope, if you're controlling the slide. So there's been a lot of work. There was a subgroup created to really look at the definition of health equity. And this was adopted in, I was going to go look up and I forgot to. Do you remember, Karen or Susan, how long ago this was put into place? About a year and a half ago?
Yeah, actually, Carly was part of the Health Equity Committee that developed the definition. I think it was towards the end of 2019. Does that sound right, Carly?
2019, yeah.
Yeah.
Wow, so almost 2 years ago. Okay, well, a year and a half wasn't too far off. You know, I think that one of the great things about that process was there was a lot of work that went into it. As Susan mentioned, there was a group that came together to do it. I know that HITOC and many other groups across the state had an opportunity to provide input to it as the definition evolved and to share different perspectives. And so without reading through all of this, I'll give people a chance, if you haven't seen it, just to take a look at this and see what that definition is that has been adopted by OHA and the Oregon Health Policy Board. And again, this will really be informative as we work on our strategic plan going forward. So thanks. I'll let you continue on now.
I wonder if, Carly, if you wanted to say anything before we move on about the importance of the definition, or any thoughts you have as a founder of this definition.
Yeah, so for context, I'm currently on the Oregon Health Policy Board's Health Equity Committee. At the time that the definition was developed, I was co-chairing the committee, and my term is actually up this winter. But, you know, I think what I would just reiterate, Eric shared, you know, a lot of feedback went into this definition, and it took multiple months and multiple rounds of getting feedback from a variety of different audiences to land on what felt like every word felt really centered and important. Age as an identity was added later after the fact, and so there have been updates to the definition. But it definitely felt in sort of driving this process very community oriented, and engagement was high. So I think we can all be really excited that there was a lot of feedback and it wasn't just kind of dumped on us as a state. So yeah.
Thanks, Carly. Thanks, Eric. All right, and next slide, please. So some background for you. Next slide, please. So here's some nuts and bolts. One of HITOC's key responsibilities is to develop a strategic health IT strategy and plan for the state. And the strategy is approved by the Oregon Health Policy Board. The last update, as was mentioned a little bit earlier, was done in 2017. And that early work started to update the plan again in 2020, but we were paused in about March due to COVID. So updating the strategy plan will result in really a roadmap for the state and incorporate the things that you see here: health IT policy, landscape, things like barriers, challenges, and gaps. We will get into that. Progress and efforts. And when I say efforts, we're talking about things that are working, and also taking into account the lessons learned of things that don't work very well at all. Then federal and state policies and laws, and all those other things that HITOC is involved with. And with that, we're going to go to the next slide, and I am going to turn it over, I feel like a host, I'm going to turn it over to Susan.
So we've been involved in strategic plan work around health IT since 2010. HITOC was established in 2009, And at the same time, the federal HITOC Act was passed, which distributed grant cooperative agreement funding to every state to implement health information exchange in those states. And as a part of that grant, states were required to produce strategic and operational plans. So HITOC started with our state ideas about what we thought we were going to do, and then the federal funding came in and really focused on health information exchange. So that first plan was done in 2010, and really how we were planning to spend federal funding. HITOC then came back to its state mandate to have a strategic plan in 2012. That was revisited in 2014 after we had launched CCOs and had learned some lessons about what was really important in terms of coordinated health IT. So there was a kind of interim document called the Business Plan Framework for Health IT that was meant to be more of an action-oriented strategy document. Around at that same time, we had new investment from the state legislature in health system transformation, and we're actually awarded some state funds to implement and carry out the actions in that business plan framework with the coordination of CCOs. So there was new funding again in that sort of 2014 phase. And then we, as that roadmap kind of wound down, we went through a process with HITOC to really fully update the strategic plan in 2017. In the middle of some of these orange years, we had other federal investments. There was the federal CMS State Innovation Model funding, which we used in 2013 to launch the EDI program, that Emergency Department Information Exchange. We had grants for telehealth pilots and other supports for focused efforts that we were able to leverage some of that federal grant funding for. We also received an ONC federal cooperative agreement to help support community information or community-based and regional health information exchange and behavioral health sharing around 42 CFR Part 2. So that was some new funding we had. And I mentioned the federal investments with the cooperation of the state investments with the CCOs that we used in 2013. So what's different about this strategic plan in 2022 is the HITOC funds are ending, and there are no new big federal cooperative agreements that we're tapping into. So while we have the opportunity to support statewide health IT infrastructure, technology, or systems that are needed for the Medicaid program, we have federal CMS funding that we can tap into for the Medicaid share of that. That's at a lower rate than what we've received in the past and requires state matching funds. So one of the things that's different now is that we need to think about what our role really is moving forward with the funding that we have, work with our legislative partners if we need new additional funding to invest in things like CIE, and understand how we can leverage the available federal funds. Like think opportunities through the waiver, for example. So that's a little bit of our history. Back to you, Karen.
Susan, and next slide, please. So where we want to conclude with all of this is really a roadmap for Oregon. And when we talk about Oregon, we are not talking about a particular funding stream or a particular entity. It's not just providers, not just payers, not just CCOs, and not just Medicaid. It's really a statewide strategic plan for health IT. So in our upcoming meetings, we'll talk more about the current state, really reviewing the problems we know, things that we've already heard from prior listening sessions. But just as Eric said, over the last 2 years, so much has changed. There's really a lot to still go back and revisit to make sure that we really have a good understanding of the problems that we have and the current state that exists. And then we'll update the vision. And it may not be, when we say update, we're going to look at the vision and see what needs to be modified on that, and really think about what we want things to look like in the next 3 to 5 years and establish goals that will then meet that vision. After that, then HITOC will develop strategies and really an action plan to meet those goals. Prior plans have really included things like priorities or aims and objectives. And it was really what was appropriate at that time to include in those strategic plans. And what we're looking at for this strategic plan may look a little bit different from what we've done in years past. And all of that is on the table. But at the end of the day, we really do want to have the plan be something that is very action oriented and can meet and really kind of leads up to steps that we can take to see how are we doing and how are these strategies actually helping us reach our goals and ultimately our vision. Next slide. And Marissa, if you can click on this, we have fancy animation and we'll just get it all out there right now. So the health IT goals from the 2017 plan, first the vision. The vision in 2017 was that we would have a transformed health system where health IT efforts ensure that care Oregonians receive is optimized by health IT. And Marissa, if you could do just a couple more clicks, I think we have a few more things to put on the page. So the vision is at the top, and then we had our 3 goals. And in this iteration, the thing that's been talked about so much is that piece that we really need to add is how health IT supports social determinants of health and health equity. Next slide, please. So launching the work. Next slide. So this is kind of our thinking around these are the steps to getting to completing the strategic plan. And there's my arrow of we are here. We are at the very, very beginning. So today we will talk a little bit about the current state, but also our setup to the approach of how we think we want to get the work done. And we want to get HITOC's feedback on that approach to make sure as we formulate our plan and our project, really our project plan to getting the work done, that it's all informed by HITOC. So I've listed here, we are at kind of the initiation stage for this meeting. Next meeting, we want to come back to start talking really about the current state and the problems to solve. Then we'll move towards the vision, setting goals, and then ultimately that last step of setting strategies and actions to reach those goals. What's not on the slide is the timing for all of this work. We hope to get through step 5 by the end of 2022. Next slide. And Marissa, if you can click again, please. Thank you. So to scope the work, we're going to start off with HITOC's priorities. Those are all listed on this page. I think you're all familiar with all of these pieces. But the thing I wanted to point out is that we will be proposing additional work outside of the HITOC meetings to get the work done. So looking at all these pieces, I'm going to talk at a very high level about all of these today. But we will be doing education sessions in between meetings so we can get more information out to HITOC members in between the meetings so that when we're ready to meet, we're ready to discuss and make decisions and really have HITOC do more of the talking during the HITOC meetings versus us really talking at you. Next slide, please. Okay, so think of these next slides as really the current state speed round. It's really the presentation is really insufficient as far as giving you a good grounding and all of these concepts. But we wanted you to just have a good sense of the kind of work and the kinds of things that we're thinking about for all these components of the plan. So the first thing is this slide really covers the infrastructure of where we are right now. So Oregon has high rates of EHR adoption, but there is still a digital divide. That's largely due to the haves and have-nots of the EHR incentive programs of who was eligible as an eligible professional or an eligible hospital for meaningful use in promoting interoperability. And EHR adoption is a foundational component for health information exchange, at least electronic health information exchange. HIE has been critical to support care coordination and value-based payments. And over the last 10 years, it has evolved significantly and changed quite a bit. And because the digital divide exists in EHR adoption, the same is said for health information exchange. Moving along, the CIE space is really our quickly evolving space and definitely the kind of emerging effort. But more work is done here, and probably the most work is needed here to understand how it can be coordinated and implemented on a statewide basis. Moving to the bottom corner on broadband. So Phil, I think that you brought this up earlier, and so did Avi around broadband. So the pandemic highlighted the need for telehealth, but broadband is not available in a wide kind of widespread across Oregon and can be definitely one of the barriers to getting telehealth services. It's not the full picture, but it is one of those things. And then when we look at patient apps, so patient apps really go straight to that patient engagement and access piece. Rules that have been talked about just a little bit before this from CMS and ONC really encourage standards that allow third-party vendors to have patient applications so patients can engage in their healthcare. And then finally, with the public health IT, this is referring to things like the Prescription Drug Monitoring Program, or the PDMP. Also, the gateway that goes into that too. Thinking also about public health registries, immunization registries, lab, disease reporting registries, and case reporting. And with the pandemic, it really highlighted the need for that very authoritative public health data to be available and accessible. That is one of the reasons why we have the Public Health Data Sharing Work Group that HIT Commons hosts, and the need for House Bill 3057 that was talked about a little bit earlier. And next slide, please. So health IT challenges, I'm going to go through these just like I went through the last slide, just kind of quickly. But on health IT challenges, the first bucket is around connecting and really that interoperability piece. So EHRs, they still face challenges talking to each other. So despite national standards for certified EHR technology, EHRs, we have a lot of different EHR vendors in the state. While Epic is the predominant vendor, not everybody has adopted certified EHR technology, and certainly not the most up-to-date standard in 2015 CERT, which has the most robust standards for patient access and engagement. With that piece though, because not everyone has adopted EHRs or the most recent version of CERT, you're still going to face those challenges. Behavioral health providers also, they were largely left out of the meaningful use incentives. And so because of that, they also have challenges with EHR technology. There's other pieces definitely underneath this one. They also really have challenges with managing specially protected health information related to substance use disorder. And COVID-19 did, as I talked about a little bit on the prior slide, really showed that need for systems to be able to be connected for public health, and then it highlighted those disparities with accessing telehealth services. And then finally, the last bullet under connecting is really looking at new opportunities for connecting healthcare and social services. This is all related to community information exchange, CIE. And then when we go down to rules and standards in 2020, so we do have the recent federal health IT rules that change the incentives and penalties that promote patient apps, is what I talked about on the last slide. And the last bullet point is related to those REAL-D data standards in Oregon that were first brought on for COVID data reporting. And now more robustly, it's in House Bill 3159. Those standards for REAL-D and also for SOGI data are not, those are the standards that we have for the data that must be reported are not the same necessarily as national standards. And while Oregon has created data maps to align some of those for reporting, it still leads to challenges in how data are initially collected and managed and then subsequently shared. We still have work to do. And next slide. So state policies and drivers, I was so glad to have Lori speak today on the waiver in a nutshell. You just see how a lot of those policies that are being proposed under the 1115 waiver, especially CIE, has those foundations in care coordination and just health IT infrastructure more broadly. For legislation and rules, and all of these, again, these are the state drivers, so we'll get to the national ones and federal drivers next. So when we're talking about state legislation and rules, Susan talked earlier about House Bill 3159 related to REAL-D. There's also the enhanced under House Bill 2086 for behavioral health, where looking at really expanding behavioral health services and access to behavioral health. And so when we have those kinds of drivers in the environment, it just really kind of pushes the need to have that solid infrastructure there. When you look at state healthcare purchasing, on this next one, OHA and the state, they are a major player in this space. OHA in particular, we have PEB, we have OEB, we have the marketplace. we also are the state Medicaid agency. And as such, we can be a leader in a lot of the policies and really drive some of these pieces home just because of our state healthcare purchasing power. And then finally, rounding up on value-based payment and the cost growth target. So value-based payment arrangements are one of OHA's primary strategies to achieving the triple aim of better health, better care, lower costs for Oregonians. And so OHA has set up a goal that at least 70% of all CCO payments to providers are in the form of value-based payment by 2024. But there's a strong underlying necessity for Health IT to be behind being able to do that well. And the cost growth target is under Senate Bill 889, sets a target for an annual growth rate for healthcare spending. The program also evaluates annually into some of the drivers behind cost increases across the board. And HIE is just one of those tools to coordinate care, which keeps costs down. Next slide. On the federal side, some of the federal policies, the one big one is definitely the CMS interoperability rule, and then the ONC information blocking rules. So the CMS interoperability rules that have been mentioned a couple times already, those rules are really to promote patient access to their own data. One of the things in there is really the bringing in FHIR APIs that allow patients to be able to access their data through third-party apps, and for vendors to be able, versus the past of patients having to have access to their records just through individual logins through each individual site where they seek care. So this is really intended to bring all of that information together and make it available in a more seamless way. The ONC information blocking rules also promote patient access to data, and they do that by really prohibiting providers, vendors, HIEs, health information networks from preventing the exchange of electronic health information. And the other piece is around requiring the exchange of a minimum set of data that's governed under what's called the US CDI, or the United States Core Data for Interoperability Standards. It rolls off the tongue. The next piece is proposed changes to privacy rules under Hipaa. So back in January, there were some proposed changes that were really aimed to break down some of the barriers in being able to coordinate care. This is one area where our office did not go into, we did not have time to go in and really analyze the changes to the privacy rule. And as we're doing the strategic plan work, if this is an area that we need to dive into a little bit more, we certainly can do that. But I just wanted to make sure that I just kind of put a pin in it right here for that. Under the potential federal funding opportunities, Susan talked a lot about how HITOC is ending, but there are still other potential federal funding opportunities that come up. For example, the Support Act in 2018 was really aimed at combating the opioid crisis and funded a lot of the prescription drug monitoring programs in states and the gateways, including in Oregon. So there are funding pieces there. The Cures Act did not have funding for things like behavioral health EHRs, where you might think that would be a great spot for it to come in. So there's some things that come in from on the federal side that bring funding in that we'll need to monitor, and then other pieces that just aren't there. The other one that I'll also pinpoint is our Medicaid Enterprise System funding, or MES funding. So as a state, for the Medicaid Enterprise to support that work, we do get federal funding under that funding stream. So as we're thinking on the strategic plan of different types of ways that can fund certain types of efforts and activities and what's actually going to be achievable, those are just some of the things that we still have to keep in mind. And I'll round out with TEFCA, the Trusted Exchange Framework and Common Agreement. ONC just, I wouldn't say hot off the press, but back in July, they did come in and say that they are looking for Q1 of 2022 to begin participation in TEFCA. That's something that I'm not sure how much HITOC has had a deep dive into some of the pieces for TEFCA, but if that's something here, that sounds like that would be a great education session coming up. Just something to note here. Before we go to the next slide, one thing I'll mention is, even though I just did a major speed round on all of these pieces, and I kind of plugged a little bit for education sessions, if there are any of these pieces here that you know that you want to have a deeper dive conversation about, Hope and Ashley will be sending out a HITOC survey. We will be asking you for topics for upcoming education sessions, and just let us know where you want us to dive in. And next slide, please. Oh, my favorite slide. Okay, questions. Okay, I'm taking that as you're ready for more. And all right, so let's talk about work groups and the process for getting the work done. Next slide, please. So these slides are really focusing on process and what our plan is. So by the end of 2022, we'll have a draft plan ready for the policy board. So as mentioned before, it's just going to take a lot more time than just having bi-monthly HITOC meetings to do all of the work. So some of the additional things that we'll be doing are definitely member surveys, which we'll follow up with you after this meeting with survey number 1. One thing that we proposed during the last session for updating the strategic plan was also hosting a HITOC retreat. So that's still something that we may do, and I just want to put it on your radar that that's an option. Then the education sessions in between HITOC meetings. This is a strategy and something that the policy board started doing, and it really allowed for them to have kind of these more deeper dive topic areas for them to dive into in between those policy board meetings. So when they were ready to meet, they were also ready to make decisions and discuss things. So we're going to be doing that same thing, and topics for those meetings will be coming to you that you can choose from. And if we don't have something on the list and you want to know more, we'll want to hear about that too. And now I want to talk a little bit about work groups. So we have a couple buckets of work groups that we're thinking about of how work groups can tackle some of the specific areas. So these are going to be work groups that are focused on things. I'm just going to throw it out there first, like a CIE work group. So a CIE work group would have these work groups that have a specific scope, purpose, and why they're meeting, and a separate membership than HITOC alone, although we're looking for HITOC volunteers to participate in these work groups. So CIE would be a new work group that we are going to be proposing, but we also have existing work groups that we've had in the past that we can rejuvenate. So one of those is the HCOP work group, or the HIE Community and Organizational Panel work group. So that's one of HITOC's work groups, probably one of the more difficult ones that is for me to say. The other one is the Behavioral Health HIT work group. So those are some of our existing ones that we may rejuvenate because we may just need a few extra details or questions that need to be figured out on those other work groups. So a couple pieces there. And then I'm going to talk about our partnership with HIT Commons and its work groups. So HIT Commons also hosts an EDDI steering committee. They host the Prescription Drug Monitoring Program Steering Committee, the PIC that was talked about earlier, which is one of my favorite acronyms ever for a work group. And then also they have the Public Health Data Sharing work group as well. So they have work groups that also have those ties into the strategic plan, and those are other ways that they can plug in. HIT Commons, so we also have Mark, who's a member of HITOC, and Justin Keller, who's on the call as well, and they are also helping us get the work done on the strategic plan. I have OHA and ODHS input and coordination in here as well. When we're talking about CIE, and Lori talked a little bit about child welfare, we will be involving our own folks in these conversations, so we make sure that we have all of the feedback that we need. And then rounding out, the boxes, it's kind of a bland color too. It's a stakeholder input and listening sessions, but this one should actually be very, very bright. This is where we really want to bring in more folks to the conversation around health IT and health information exchange, opening up public listening sessions as well. We did this early on in the strategic planning process in 2020 when we were just rejuvenating this work again, and we had kind of a patient listening session. We may need to do that type of listening session again. It may take a slightly different form, but we really are looking to get maximum input from maybe those who we don't normally engage, just because it's health IT. It can be very, very technical, but it definitely affects patients, and we definitely want them involved, consumers, patients, community involved in this plan. So staff will be seeking, as I mentioned earlier, I'll just emphasize again, staff will be seeking volunteer HITOC members for work groups and other opportunities to advise us. But the CIE work group is not the only work group that we have. There's a lot of things and a lot of opportunities out there for volunteers. And next slide. Okay, so our plan for the rest of the year really just breaks down into, first, we want to work on the first chunks of the plan. And so that's really understanding the current problems that exist today, the vision and the goals. Then we want to start on the education session. So I talked about that a number of times already. And then the third piece is looking at chartering a work group. So when we're talking about chartering a work group, and our proposal for you today is around CIE, some of the reasons why we might want to start with a CIE over a different work group. So we have work to do on health information exchange. We have work to do on EHR adoption, work to do around patient access. But CIE is one of those emerging areas where HITOC hasn't really had a deep focus on in the past. So there's a large amount of work and it's a large amount of emerging work. But I probably should have led with this other piece, is that CIE is one of those things that's really rooted and focused in health equity. So there's a strong health equity focus and social determinants of health need that are all addressed under this CIE umbrella. And so with that, that's kind of the prioritization for CIE. And with that, I am going to turn it over, come up for air. And so I'm going to turn it over to Lisa Parker, and she's going to talk a little bit more about the CIE work group. So take it away, Lisa.
Great, thank you, Karen. So I'm Lisa Parker. I'm the Director of Health IT Policy. And you keep hearing about Community Information Exchange, or the acronym CIE. I want to make sure that for those of you that aren't familiar, at least have the working definition for you on the right-hand side. We essentially think of CIE as a health IT tool that connects people to meet social needs and contributes to a system where care is coordinated. Often people refer to it also as allowing for closed loop referrals to happen to social services so that people know what actually happened with the referral. So CIE efforts are developing rapidly throughout the state. COVID accelerated the adoption and spread. This has all been happening quickly. Our office has been monitoring it for a couple of years, but HITOC has not had the opportunity to set strategic direction related to CIE. And we think that's really important. Then how do we dive into the topic more deeply? And we thought the work group was one of those really good starting places to do that. We think the scope of the work group would probably be pretty well known and that we could charter it quickly. So we also think by having a work group and not just the subgroup of HITOC, it allows the opportunity to have more in-depth discussions with stakeholders that are affected by CIE directly, and that the work group would then give HITOC recommendations for the strategic plan. We also, as it was mentioned several times, see that there may be opportunities within the waiver, the Medicaid waiver, and OHA may have to act quickly in response to that, and we want to plan for it. So we're looking for a forum to get stakeholder feedback on those opportunities if they come to fruition. Next slide. So the timeline. What we're thinking is right now, if HITOC agrees, the staff in OHA will be working on developing a charter that we would then come back and propose to you in October and have you guys vote. And then at the end of the year, we would start recruitment for members and then convene the work group starting in 2022. Next slide. So the CIE work group focus would really be that this work group would provide recommendations on the strategic direction for HITOC to consider actions for CIE. The topics may include how to support health equity, including identifying barriers for community-based organizations, particularly culturally and linguistically specific organizations. We also want to look at options for statewide approach, including state agencies' participation, look at funding models and incentives for participation. We think there are many organizations that may face barriers, and we need to look at how to help them accelerate their adoption or help with workflow. We also see that this is an opportunity to how to collect data and use that to inform policy decisions, and we'd want to use the information collected to figure out the best way to do that. And another big component of this is evaluating whether legislative changes are needed to support statewide participation. All of these topics that we've suggested really come from the foundation of House Bill 3039 that was proposed in 2021 legislative session, but it did die. And we think that was a good starting point. Next slide. And so we want to have a discussion with you. First, I'd really like to just hear some feedback on the content of the work group and see if you have any concerns or comments or things that you would like to see be included. So if we could go back to the previous slide so that everyone can see those topics. And so does anyone have concerns or agree with these focus areas?
Lisa, I think there's a comment in the chat.
Okay.
Question about patient access through CIE.
Okay, I'm sorry, I have to, oh boy. Too many things loaded up. So can someone read the chat?
Sure. Or Amy, do you want to mention your comment?
Yeah, I was just curious, as we're looking at health equity, is there a role for the client to be in that sort of triangle of referrals and, you know, social services and healthcare provider, instead of it just between those two entities?
So it depends on which solutions communities are adopting. There are different models where the individual recipient may have direct access or it's done on their behalf. But the individual is always a part of the consent process to participate.
I have a quick question. This is Diane.
Okay.
Do we have a good sense of outside organizations or community organizations? I'm trying to put this in perspective, that have a mechanism for electronically exchanging information? Do we have a good sense of that, or do we have a priority, or do we want a priority to say it's most important to have, I don't know, homeless databases and organizations that help food banks, you know, those kinds of things. Those two things came to mind when you were talking on this slide.
Yeah, so when we talk about community-based or community information exchange, we're really talking about the solutions that have this closed loop referral mechanism. So they have a shared resource directory where referrals can be made to resources, and then the person who referred can actually receive the information back about what happened, and that's the closed loop referral. There are two main vendors that have presence in Oregon, and we've been monitoring that. It continues to spread. So we're really looking at that as the area, those two vendors being Aunt Bertha and Unitas, or the Connect Oregon effort is what they're known as. And then we think a part of looking at this is interoperability with other systems. We see everything as needing to be connected in some type of network, and looking at the homeless database would be, the HMIS system would be a part.
I just think those two pieces of software functionality, they're there, but it's the other end of it has to be able to communicate in order for that to work correctly. And I don't think we've seen that piece of it.
Okay. I think that's something we need. Susan, did you want to comment?
No, I think that's a major component, right? Is what are the challenges that community-based organizations face in participating in CIE, and what kind of strategies or efforts could we undertake that could support that? I think that's exactly in line with what this work group would dive into. I know Carly has her hand raised.
Yeah.
Yeah, that's a good segue. You know, I have a couple I have one comment and then more of a question or recommendation. I definitely, I think these are the right topics for sure when I look at kind of what's on the screen and around, Diane, what you're saying, the incentives and funding piece that would make it palatable for CBOs or reasonable for CBOs to engage in CIE is a really worthwhile aspect of this conversation. I'm thinking about my work with the health centers who were even better resourced, which is unbelievable compared to some of the CBOs in our region and our state. And so how do we balance who has the resources to participate in data exchange and technology? I think that's a really big question. And then I'm also, I'm thinking, the pre-COVID, there was a CIE advisory committee that came together. I sat on that for, I think, 3 months before we disbanded. And I wonder if there were big takeaways or reporting from that initial effort that had a pretty good set of individuals around the table that could be lifted up as a starting place for this work group.
Yes, I think that is a great starting point to make sure that we're looking at anyone who was participating in that, and the information that we learned from that group then is a segue into this group moving forward. So I definitely agree with you on that.
Casey?
Yeah, I just wanted to mention from a public health perspective, providers have a lot of apprehension in collecting social determinants of health information. But when we sort of scripted the collection of that data and the training with those providers to really inform them that we can't put resources into these areas without knowing what the needs are. Yeah. So that actually changed the conversation tremendously. They felt a responsibility to take action, and we didn't have the resources necessarily in the community, but just in the sense of gathering that information and collecting it in our system, in our EHR, then we can start looking at that need in a more holistic way and identifying the areas in the community and where we can maybe do a drop truck for food boxes or a dental van in certain areas. And I know this isn't necessarily an original thought, but that does change the conversation and change the provider's apprehension in collecting that information so that we can have a better approach in the community to address the needs that we've identified. So it kind of takes that pressure off those providers to necessarily take immediate action. The referrals are obviously very important, and that's how we gather that information. But if the referrals exceed the resources we have that information to really focus in those resources in certain areas to meet those needs. So that for us has been a really important part of collecting that information and meeting those needs in the community and using the data in the system to sort of support those efforts.
Great. Dave?
Thanks. This is a topic near and dear to my heart, having worked a lot in social determinants of health and trying to, in our patient populations. So I really like this. I think you've heard the technical capabilities, especially on the CBO, and the sort of cost to do that is really important. The data standards here are tough as well. I mean, that's part of it, but there's a big leap there. So I really do think the group has to look at readiness. What are the needs and requirements that would optimize this? I think it's in speaking before, really about all kinds of information exchange, this is one that's highly focused on really important issues. And so, that's the kind of, one thing that I'd like to say, other than sort of supporting it, thinking about technical capabilities and readiness and the impact therein, is this is one kind of information exchange, and this model should maybe drive the way we think about information exchange for the next stage, which is more like, what good can it do for people in receiving the best care or getting the services that they need to optimize their health. So I really like that. I do have to say, this issue about personal access, having worked on a number of these projects where we ask these questions, people's readiness, individual readiness or desire to seek these resources is so crucial in this, and there's some evidence that there's a big gap sometimes in sort of identifying needs and then people's desire to seek them, or readiness to take that next step as well. So I do think there's got to be this individuals, this representation from the community for that, or at least people who've sort of worked on this before, as you've mentioned, because it's quite a sensitive topic sometimes, and there's issues of trust that could worsen inequities if it's not done carefully. So I do want to highlight that as well. But otherwise, I think it's great.
Great. Thank you for the feedback. Oh, Abdi.
Thank you. Yeah, this is wonderful. I just want to share two cases in Maloma County currently I'm working on. One is a WIC program wanted to have the, connect to Oregon, so that they can get the referrals from outside and serve the community. But unfortunately, they have a twist, which is state, on database, which was very difficult to connect twist and, connect Oregon. So they have to go separately and then have that basically portal access through the referrals coming from Connect to Oregon. But one successful area that we're currently working on is Connect, Oregon, which brings referrals coming from social services and connecting that to our Epicare system. So that is in the working. So that is where the real magic happens, where you get the social services referrals and connecting that to our Epicare system, electronic medical record system. So that is in the workings right now. So I'm very excited to see similar system is having. I mean, the gist of interoperability is about having multiple accessing data from multiple systems under one application, right? So that is where we're heading and working, although it's a little bit clunky, but it's a place to start. So I just want to share that real case here.
Great, thank you.
Amy Fellows, did you want to, looks like you had a comment about decolonizing data work?
Oh, I was just curious if anyone from that's been involved in that work has given input to this.
Not that we're aware of, but that's a great call out.
Yeah.
Yeah. Great.
Okay. Any other thoughts on the content? Okay, let's move forward to the next slide. So, Bill, you got a little bit ahead of us. We have already asked if Carly, being new to HITOC, but Carly really comes to us with a strong background in social determinants of health, and it understands a lot of the screening behind it. So we've asked her to help our staff put together a draft proposed charter for HITOC that we would bring to you in October for you to review and approve. We want to capitalize on her experience as well as her experience with the previous Cie Work Group. So that was our starting place. But before we move on to that, I want to see if anyone has concerns about us bringing a charter to you in October. Does that timing seem right? I'm going to take the silences, meaning you agree. So
I think
we
we're looking for consensus, not necessarily an action. I don't know if that's where I jumped the gun there, Lisa. Sorry.
Thank you. Okay.
Yeah. So I guess our request is, does it sound good that we're going to move forward and bring back a charter? If we have other folks that really are interested in helping advise staff on developing the charter, let us know. We'll include some of that in the survey that goes out after the meeting. But yeah, anyone have any major
It seems like it'd be
concerns?
good to make sure we get some of the HIT comments input onto the charter, given the work that's going on with OHLC.
Yeah.
Great. And then one other thing we want to get your feedback on is orientation around the CIE subject. We do at the bottom of this slide have a link to a webinar that we did back in April on CIE that is an hour and a half where you can fast forward if you'd like to listen more about what CIE is. And we had community stakeholders who are participate as well as present, as well as some of the CCOs. There's also a link to the slides if you didn't want to listen to the recording. But one option is we could bring CIE as a topic to one of the HITOC education sessions so that we give the opportunity to talk more about CIE and what it means for HITOC. So just wanted to put that out there and see if anyone thinks that HITOC would like something specific, or if you think listening to the recording is sufficient.
Lisa, I think it'd be a great idea to offer that to HITOC.
Okay.
I'm sure we all get on the same page and are looking forward at this with the same base level of understanding.
Yeah. Great. Okay. I think with that, we can move on to the next topic. Thank you, everyone.
Thanks, Lisa. I'm sorry if you can hear a background bird who is really noisy. So if there's background sound, I'm very sorry. I do want to show you the proposed timeline of what we're talking about here. So, and proposed meaning this is out of the gate and definitely subject to change. One thing we didn't talk about though is down on the development timeline. So I thought the next time we want to dive into really understanding the problems that exist today and getting a better handle on current state. And by February, really wanted to kind of sync up the problem, the vision, and the goals. One of the things Lori talked about, and it's been great on the waiver, is as they've gone through their process, which has been very iterative, they have produced these draft concept papers that allow folks to get feedback and then revise and provide more information that ultimately will feed the waiver application. And I'd love to do that on this project as well, where as we kind of move through these stages and iterations for the strategic plan, that at the end of February, we have really a concept paper of our problem, our vision, our goals that we can use to present to put it on our website, have listening sessions with consumers, patients in the community, and get feedback all along the way as we are continuing to develop the application. So as we go, these are like really kind of drafts that we'll publish and get that feedback. So you can see in the middle of this slide, I have stakeholder feedback and input, and that is really to represent that in addition to HITOC with these public meetings, that will have other opportunities for feedback and input, including from patients and really wanting to reach out to those who we haven't engaged in the past. I have some kind of milestone-ish markers at the bottom of the timeline slide where we show the kickoff of today, ending with the draft to the policy board at the end of 2022, and then some other pieces in between, just to give you a sense of process of how we're approaching the update. I'm skipping around completely on this slide, but I also want to mention in June of 2022, that's when I'm thinking we'll have better strategies. And what I called here milestones and activities, I have really kind of changed a little bit of how I thought about the action pieces for and making this strategic plan very actionable. So it could be a listing of activities and how those link up to strategies. It could be milestones that we want to reach and setting outcomes and goals within those aims and objectives. That milestones and activities is still a little bit fuzzy at this point of what we really want it to look like, but I really want the group to help to formulate best ideas for how to make this strategic plan actionable, and we'll work through those processes. All right, and next slide. So the process here, this is just a recap of how we expect to get the work done. One of the things that we really wanted to do today was do breakout sessions with all of you to dive into additional questions. And with the time of where we are right now, I'm not sure we would have as much time to do that because we were really expecting to spend at least 40 minutes to get through that process. So one thing we could do, Susan, HITOC, and group, is we could tackle one question as a group and get your feedback and just make sure that we are on track for this process and make sure that we haven't missed anything so far. So I'll see what you all think about doing something a little different than going through our pre-formulated questions that we had.
Eric, I'm suggesting maybe we pause and go into public comment so that we then know kind of how much time we have left in the meeting, and then we can come back to the discussion questions and go into those as a group altogether.
That sounds like a great idea, Susan. Thanks.
Okay.
So we will do that. Is there anybody here today outside of HITOC members that wanted to make a public comment on our meeting today? Give people a second here. It looks like there's a few non-HITOC people on. Anybody have any public comment for today? All right, well, hearing none, we will close the public comment period. And did you want to do anything on the HIT program updates? Or are you just going to refer people to the write-up, Susan, and just finish the rest with the strategic plan discussion?
Yeah, I think for the interest of time, we'd love to get a little more discussion from folks about especially how you see engaging stakeholders and centering equity in this work. We've included a written programs update that we include in all HITOC meetings. That includes some updates on federal policy and state policy, as well as our programmatic work. So I think we'll skip over that agenda item and just refer folks to that document.
Great.
All right, so Karen, I think we should go back to our discussion question.
All right. So in the interest of time, so later meetings, hopefully we'll have more time for breakout sessions so we can have folks break up into smaller groups. But for this one, we had four different questions that we were proposing. I think just to get through them, we can tackle them all as a group and pick one. So Susan, I'm proposing we go to question 4, which is really around planning as a whole. But if there's anything in particular that we've missed that's a little bit more specific that you want, that HITOC members want to call out, I would love to hear that as well.
I think that's fine. I think we're really interested in your feedback as well, and maybe we can include a request for additional feedback in the email follow-up. And yeah, let's start with that last question. I think it's a good broad question, so we can fold a lot of things under it if folks have advice they want to make sure to pass along.
So Marissa, if you can click through the first 3 questions. Oh, 4. 1, 2, 3, and 4. And one thing I'll say too, if any of you are really interested, if you've seen the questions that we were going to ask and you have, and you would like to share any of that feedback with us, please feel free to do that. And actually, we can go back, just back one, please. Thank you. So looking ahead at this work for the strategic plan, 3 questions. What do you think will be most challenging? What are you most excited about? And ultimately, what do you hope to see when we're done?
I think folks can type into the chat as you have thoughts, or raise your hand and share them verbally. Thanks.
And maybe I'll add one more question, just because we're at the beginning, is what, if anything, are we missing and we want to make sure that we add to the process, or what we're thinking about? These are great. So I think I'll just go ahead and start reading them from the chat, and then hoping to encourage, if you want to unmute and talk about them as well, that would be great. So Amy says she would love to see telehealth planning and ways to increase access telehealth from an equity standpoint. I think that's great. And Dave Dorr on challenging the amount of federal legislation around HIT and HIE has been staggering. True. And most organizations are struggling to understand the impact and what they should be doing to meet requirements.
And there's more likely coming.
It's endless for sure. And Bill says consumer feedback may be made more difficult if we continue to have COVID outbreaks and fears the next variant. A very good thing to note. And Diane agrees about telehealth. And Manu, for something challenging, says integration across all providers. And Manu, can you, I would love to hear a little bit more about that. Can you say a little bit more about that, about types of providers that you're talking about? I know that you talked so much about oral health and that need, but are there other pieces that you want to add to that too? I say all providers.
We're not hearing you, Manu.
Darn it, there I did it again. That's two for, I guess.
Now we're good.
Okay. So yes, definitely not only just dental providers, but pretty much everyone, you know, kind of like in kind of how you say, like, you know, that with the tide, all ships rise. And so that's what I'm really hoping that we can kind of bring together in that future where we all kind of grow together appropriately. But I think definitely what I hope to see with the work is kind of centralizing some of the stuff within, as opposed to potentially piecemealing it. I don't have any details of that yet. To me, this is, I'm just learning and absorbing as we're going along.
Oh, that's perfect. Thank you. Okay, and then just moving through the chat, will the CIE work get input from the RECs and other groups of CBOs? Oh, and this is from Amy Fellows. I am working with a network of CBOs in Lane County that the Public Health Department is bringing together on COVID work, but other topics as well, focused on health equity. I think informing, I'll start with my answer and then have other folks from OHA add in as well. So I think absolutely, and I think that's part of doing the work of the CIE charter, is kind of really scoping out the types of folks who we need to make sure are at the table for those conversations, and making sure that we get those folks in the recruiting process. Susan, Lisa, did you want to add anything else to that?
Yeah, I think one of the things that we've really committed to internally is really understanding community-based organizations that work with culturally and linguistically specific populations, and any specific concerns or issues they have, or I shouldn't say concerns, but challenges or other issues related to community information exchange. And I think diving more deeply into that topic may require work outside of the work group may inquire specific listening sessions or other stakeholder engagement. And I think the RECs, Regional Health Equity Coalitions, and other culturally and linguistically CBOs will be really important, folks for us to be hearing from. So great call out.
I'm glad that point has been raised, and I can speak to that, some of those experience as someone who has always been a community leader and worked with diverse, CBO, a number of organizations here. One of the challenges they will always tell you is not having enough broadband, right? Capability or internet where they can access telehealth for their families or individually. That is a major barrier right there. Another major problem that you will see or encounter, and even families will share this with you, is that, for example, some of the folks might not be able to have a smartphone, where in order for you to access your telehealth, you have to have your smartphone. That's very expensive these days. Some of them might not be able to afford that with different plans that they have. So it's very difficult for them. So you will see those issues coming to the forefront if you ever talk about telehealth. So how do we invest that basically and address those challenges basically that the community experience? The other issues that I heard a lot about is, for example, the number of organizations themselves and having a system. What kind of a data platform system that they can purchase that would be able to also capture their clients' information at the same time, share that information with the state or basically the county or federal government. So their systems are not trusted because it's not secure or does not have a lot of does not meet or it's difficult for them to comply basically a lot of HIPAA compliant issues or HI health information systems that are required for any systems to have to operate within the state, and also and it's very difficult for states and counties to trust those systems that they don't have any control over it. So these are the major challenges basically that you will see when you talk to those number of organizations basically. So I'm glad that right now we're seeing a Connect to Oregon coming to those number of organizations, working with them along with 211 and state and the county level is just the beginning. That's what I'm seeing right now for the first time in my line of work, and also on the work and off the work as well, working with a number of organizations. So I just want to share those with you.
Great, thanks, Abdi. Other comments or thoughts? One of the things that I almost kind of commented on in the beginning, while I am excited about and appreciate and have been supporting even some of the CIE work, I sort of look at some of the work we've done on, or that we laid out in front of us for just basic HIE and HIT, and that work's not done. And we really need to, I don't want us to sort of lose focus on some of the original things we were trying to accomplish. And I even look at the behavioral health HIT report that came out that really showed some severe gaps there. When I look at how much of a priority that is in, particularly for OHA for Medicaid, I think we have to really think about how do we solve some of those issues and balance that with sort of adding to the portfolio when we're not done with the things we started out to do.
I made a comment in the chat about sort of ensuring we have equitable community engagement in the strategies, whether they're CIE or behavioral health or whatever it might be. I think my organization, Project Access Now, spends quite a bit of time doing outreach in a very diverse set of communities, and the staff reflects the communities we serve in the Tri-County area, and they have a lot of trust, and they struggle to get a lot of largely undocumented and immigrant communities access to care and build that trust. And so I think we need to be really mindful of who we're hearing from, why we're hearing from them, and how we make sure we hear from everyone. or those that are most impacted by HIT, who, as I said in the chat, frankly, probably are more worried about food for dinner than they are about their HIT record.
Thanks, Carly. I think that is something that we as an agency have struggled with. Some is how do we truly engage community in the policy work that we do more broadly. And there's a lot of lessons we've learned going through the waiver process and some input around that's informed the OHA strategic plan. And so we're looking to learn lessons, but also want to harness the assets, you know, the expertise we have on this group, as well as we think about how do we effectively engage the all stakeholders in giving input on the work this work that impacts them. And so we're hoping to learn and improve. Thanks.
Just as a point, just to share, you know, the special needs community is pretty near and dear to my heart for many years now. And so whatever we build and whatever we do, if we can make sure that this is equally equitable for them as well.
Thank
you. This is Abdi again. One thing that I would have loved to see shared in our presentations today would have been the map of Oregon with the 36, you know, counties, and just having stars or just to pointing out basically, for example, who's connected to whom, who have basically broadband access, who, you know, 60 different hospitals located dotted around the state, and they're how are they, exchanging information through either electronic medical record or ODI or pre-manage. That would have been wonderful to see that, and juxtaposed by population as well. That would have been wonderful to see that picture visual thing. It would have been helpful. Just want to point that out.
Thank you. And I think that environmental scan, we've done some really great work ahead of our prior strategic plan, you know, that we were planning to do in 2020. And we will be wanting to orient HITOC and new members to that, what the data that we do have. And I think I always want to hear from folks what, you know, pieces are really important to bring to you that will inform that. So we do have a lot of that data. We'll make sure to send out the data report that has some of that from end of 2019. And then that's great input for us. I know we've got a few other things in the chat and we're coming to the end of the meeting. So I think we should go ahead and wrap up. Thank you everyone for your comments today. Karen, did you have any kind of closing remarks?
I just want to thank everybody for engaging today and for really giving us great input on the process, as well as just learning more about your experiences that you've had. So more to come. We'll see a survey from us coming for next steps, but really just to thank you so much for your participation.
Great. And I think as was earlier mentioned, there was also reference to a survey coming about communication preferences. So if people could respond to that, that would be great. There's also upcoming education sessions. So certainly participate in those where you feel it would be helpful to you, and hopefully that provides good information. One of the things we're trying to do a little bit is shift some of the kind of information and education sessions to outside of these meetings, so we can hopefully have a little more discussion here and not have it just be presentation. And so get that mix right. So definitely try to engage in those discussions. I would also just thank the new members that joined us today, and thanks to all of you for jumping in. It was great to have people actively participating and making comments and asking questions. So that was exciting to see. And with that, we will wrap up right on time and adjourn our meeting today. Thanks everyone for participating, and enjoy the rest of your week and your weekend.
Thank you all.
Bye.
Bye-bye.
Thank you.